This conference will now be recorded.
Let's start. Good morning, everyone. I think all of you are arrived. Okay. Today, my topic of discussion is plain abdominal radiograph in the current scenario. And my name is Dr. Pavan Kumar. My moderator is Dr. Rabia ma'am. Okay. Assistant Professor of Radio Diagnosis. Coming to the plain abdominal radiograph, this is very important. If you go to the internship, okay, I will little bit discuss about the basic principles and at what conditions we have to take the plain abdominal radiograph and what we have to look at in plain abdominal radiograph and what is the normal anatomy, what we have to see in the plain abdominal radiograph and what are the review areas we have to check it out. Okay, am I audible? The plain abdominal radiograph is an abdominal X-ray. Was for generations the principal investigation in the acute abdomen. You all know about what is acute abdomen. Okay, in most of the situation, either ultrasound or CT has replaced abdominal radiograph as a fast imaging investigation after clinical assessment of the patient by a senior physician or medic. Okay, there are still scenarios where the abdominal radiograph is very useful. Okay, this is the thing we have to know. What are the current scenarios, in what conditions the abdominal radiograph is still very useful. Okay, for non-acute condition situations, I will explain you there are relatively small yield of information from the plain abdominal radiograph in non-acute situations. Okay, they actually very little small yield of information means we don't get much information what is the condition in the abdominal radiograph. Okay, we do not conclude whether it is obstruction, it is an infection. Okay, in most of the infections, it won't be possible to recognize on abdominal radiograph. And it does not justify the radiation dose that it entails. Okay, you all know that during abdominal radiograph when we are taking, we use a high radiation, higher than the normal chest radiograph. Okay, in that conditions, the radiation dose it entails, and we are getting very little amount of information. Sometimes no information you will get. Okay, so it does not justify. There are exceptions, such as in the follow-up of renal calculi. You all know that renal calculi will be visible sometimes in abdominal radiograph, and in assessment of bowel transit times in constipation. Okay, coming after that, in the acute abdominal setting, the plain radiograph should only be considered in situations where it is likely to yield very useful information, which will impact the diagnosis of the patient and the management of the patient. The plain radiography remains the useful in diagnosing perforation of viscous and assessing the bowel dilatation. Please make a note of this tool. The plain abdominal radiography remains useful in diagnosing perforation of the viscous and for assessment of bowel dilatation during intestinal obstruction or interception or some other conditions which may lead to the bowel dilatation. Okay. And perforation of viscous. In perforation of viscous, we will see a pneumoperitoneum. Okay. And others. In plain abdominal radiograph, it is useful in diagnosing common inflammatory. It is not useful in diagnosing common inflammatory conditions of the abdomen, such as acute appendicitis, diverticulitis, cholecystitis, and pancreatitis. Please make a note: any inflammatory conditions of the abdomen will not be recognized on abdominal radiograph. The one thing we will recognize, that is calcified chronic pancreatitis. In that conditions, the calcifications will be visible in the abdominal radiograph. Okay. Any conditions, suppose in appendix, if it is calcified, that we will normally know porcelain appendix and porcelain gallbladder and chronic calcified pancreatitis. These things will be possible to recognize on abdominal radiograph. Okay. What are the indications for the plain radiograph in acute abdominal conditions? Suppose if we suspected viscous perforation, that is bowel perforation and bowel obstruction, and assessment of bowel wall pattern. That is during ischemia and during colitis, we will assess bowel wall pattern and an intra-abdominal foreign body. Okay. Suppose in children, in pediatric population, they used to eat whatever they grasp in the floor and some other things, and some batteries, some other conditions, some coins. Okay, in that conditions it is useful. And these are the indications for the plain abdominal radiograph. And coming to the radiological evaluation of interstitial gas should include the following. Okay, when we will get gas during perforation and some other conditions, I will tell you what are other conditions we will get gas and perforation and what we have to look in the abdominal radiograph. First, in that conditions, the identification of bowel segments which containing gas are important. What bowel segments? Small bowel or large bowel or maybe duodenum or stomach, and these things we have to look at. And assessment of the caliber of these segments, and we have to know that what caliber of the segments. For large bowel, how much is the caliber, and for small bowel, how much is the caliber, and for cecum, I will tell you at this point of view that we have to know that 369 principle. What is the 369 principle? The small bowel diameter will be maximum up to 3 centimeters. Okay. After that, large bowel will be 6 centimeters. That is the maximum you have to take. If it exceeds 3 centimeters of the small bowel diameter, then we will call it as a small bowel dilatation. And likely the same thing for large bowel, that is 6 centimeters, and for cecum it would be 9 centimeters. Okay. This is very important principle in detecting which bowel is perforated. Okay. Just make a note that 369 principle mostly will get in your NEET exams also. This is the important thing you have to know. Okay. Next, after that, assessment of the most distal point of the passage of the gas. Normally, normal bowel, we will all know that normal distribution of the bowel gas at what levels, what I will show you in the next slides. Okay. The assessment of the most distal point we have to know for the passage of the gas, and up to which point the gas we are seeing, up to up to duodenum we are seeing, up to the small bowel we are seeing, up to cecum we are seeing, up to large bowel, that is ascending colon, transverse colon, descending colon, or rectum, and we have to see all the bowel loops and we have to make a note. Okay, and then evaluation of the bowel counter. How is the bowel counter? The outcome which is which should be outlined by a gas or not during some perforations. Uh, Inside the bowel we will get air, and outside the bowel also you will get the gas. That is the perforation under some other conditions. So in that conditions, the bowel will be placed center, and both sides you will see gas shadows. Okay, I will show you in feature size, that is called a regular sign. Okay, I will show you in the next slides. Okay, coming to the normal bowel gas patterns, I will show you in the slides. Okay, the first collection of the gas encountered from the top of the radiograph is usually the antrum and the body of the stomach. Okay, in the left upper quadrant. Okay, normally left hypochondriac region. Okay, after that the gas may be seen in the transverse colon immediately inferior to the stomach. Okay, the large bowel loop, the transverse colon or, and the splenic flexure you will see below that stomach, inferior to the stomach immediately. Okay, and gas in the ascending and descending portion of the colon usually occupies the lateral margins of the radiograph. I will show you in the next slide. Okay, if you want, you will see here in this image, these are the lateral, this is the ascending lateral sides of the abdominal radiograph. This is descending colon and this is ascending colon. Okay, and then this is hepatic flexure, and we will see a splenic flexure here. Okay, I will show next. The gas in the ascending usually occupies in the ascending and descending colon, the lateral margins of the peritoneal cavity. The sigmoid colon occupies the inferior aspect of the abdomen. Okay, I will show you, and is often recognized by its characteristic shape and haustral folds. Okay, normally large bowel has haustra. This is the thing we have to look for large bowel. This is the characteristic of the large bowel. And for small bowel, we will usually look for a valvulae conventis. Please make a note of these two. They are very important in identifying large and small bowls. Okay, for large bowel, haustral folds we have to see, and for small bowel, valvulae conventis. And then we have to look for the rectal gas which occupies in the midline portion in the pelvis. Okay, and generally it extends the level of pubic symphysis. And the gas filled small bowels tend to occupy the central positions. The small bowel, all small bowel, you will see in this all small bowel will occupy this position. Okay, here we can get ascending colon. After that, the transverse colon we will see here, and that descending colon we will see laterally. After that, we will see a sigmoid colon here, and then we will see rectum here in the pelvis. Okay, this is the sigmoid colon, and this is the pelvis. And we will see cecum here. This is the ileocecal junction. Normally, appendix lies here. Okay. The gas-filled small bowel tends to occupy the central portion of the abdomen and has a smaller caliber than the colon. Okay, I already told you that normal colon is maximum diameter is up to 6 centimeters. Okay, a small bowel, the maximum diameter will be 3 centimeters. This is the normal abdominal X-ray anatomy. You can see here these are the ribs. And then you can also appreciate the liver shadow here. Okay, on the right side, and on the left side we are unable to see clearly here. Actually, it's a part of splenic okay, area. After that, and what other things we have to see in the abdomen radiograph, I will show you in the next radiograph. Okay, and we will also see the spine here from L1 to sacrum and coccyx also have seen, and both iliac bones are seen, and these are the things normal viscera of the abdomen. Okay, this is the liver outline, and this is the splenic outline, and these are the kidney outline, renal, and we will see the ureter, how we have to say, and these are the vertebral bodies. These are the transverse processes. This is the spinous process. Okay, and these are the pedicles. And the one thing we had to look in the abdominal radiograph is the psoas muscle. Okay, this is the psoas shadows. Okay, they are colored as brown color, and these are the ureters will come and will join the bladder and the lateral. Okay, this is the urinary bladder, and these are the iliac bones, and this is the neck bone. In this image, I will also show you. This is the ascending colon, and this is the transverse colon, and this is the descending colon, and in between these you will find small. Okay, and here we can see the rectal gas also. And what are the review areas in the plain abdominal radiograph? First, we have to focus on the gas within the bowel or outside the bowel. We have to look for the gas pattern or normal gas patterns where we are finding the gas pattern. Okay, after that, if there is any dilatation of bowel wall or any edema of the bowel or any pneumatosis means gas within the bowel wall. Okay, we have to look for any pneumatosis or any edema, any bowel dilatation of the bowel wall, and we have to look for psoas shadows if they are widened or absent or outlined by any gas. In this can normally they are obscured during actually normal bowel gas also will obscure these shadows. Apart from this, the pathological conditions in which hydroeritonephrosis, polycystic kidney disease, ADPKD, and all other renal, which leads to obscuration of shadows, and in some renal abscesses, pyelonephritis also, and then emphysematous pyelonephritis also. These will be obscured. Okay, and look for any abdominal calcifications. Okay, in this area, appendix, if it is calcified, and sometimes you will find calcifications in the bowel itself, and sometimes you will find foreign body calcifications, and sometimes some bezoar also if they will calcify. Okay, and apart from that, the last thing we have to see clearly is the gas. Is there a gas within the rectum or not? This is the very important thing we have to do. Okay, if the rectal gas is absent, we will suspect, we have to suspect there would be any obstruction symptoms. Okay, if the patient having symptoms or not, whatever it may be, if the rectal gas is absent, it means there is an abnormality. Okay, like coming to the pneumoperitoneum. Okay, just I will discuss today that one of pneumoperitoneum only for you. Okay, in the pneumoperitoneum, when reviewing the plain abdominal radiograph, it is important to be able to attribute all the gas to normal anatomical structures. Okay, normally viscera, I have already shown you there are numerous causes for gas in abnormal places. Okay, the most frequent pneumoperitoneum, but other causes include gas in the retroperitoneum and gas in the gallbladder, gas in the biliary tree, that means in the gallbladder. Biliary tree means in CBD, and in sometimes in liver, kidney, urinary bladder. Okay, and within abscess, during some abscesses, during appendicular abscess, some pyelonephritis, these conditions. Okay, you will see gas in abnormal places. Okay, most frequent is the pneumoperitoneum. Okay, apart from that, in these all in the peritoneum, in gallbladder, in biliary, liver, kidneys, urinary bladder, and within the abscesses also we will know. Okay, the presence of free intra-abdominal gas almost always indicates perforation of discus. Example, perforated peptic ulcer. This is the most common condition. Always you will find gas under the diaphragm. Okay, and other conditions perforation includes obstruction, inflammatory conditions, bowel ischemia, and injury during colonoscopy. And during these procedures also you will find intra-abdominal gas. Okay, the presence of free intra-abdominal gas always indicates perforation. Okay, and approximately 70% of peptic ulcers will demonstrate free gas. Please make a note. Mostly during peptic ulcers only you will find a free gas. In 75% of the times it will be noticeable on the abdominal radiograph. In other conditions it is rarely seen, and this phenomenon is rarely seen in case of perforated appendicitis. Okay, and small amount of gas are detectable under the right hemidiaphragm on erect chest X-ray. Okay, nowadays we will normally prescribe, normally advise, erect chest X-ray for the detection of any perforation. We look for any gas, okay, in the abdomen. Mostly during any perforation, we will see gas under the diaphragm. Okay, we will find in most of the situations we will find gas under the diaphragm. Okay, we have to distinguish these things. The lung margins we have to look for, and then below that we will find liver shadow. Okay, I will show you in the next slides. And the outlining the smooth surface of the liver clearly. Actually, you will see at that place behind the hemidiaphragm. We will see due to smooth surface of the liver inferiorly. But on the left side, okay, in right side we will normally having liver. Okay, then we will clearly delineate that gas is there in below the diaphragm, below the hemidiaphragm, but not at the left side. On left side, what will happen? The stomach will come on left side. Okay, normally stomach air bubble will be there. Okay, and it is difficult to distinguish free gas because of the stomach or colonic gas will be there. Okay, normally splenic fracture and some stomach will be there. Okay, it is difficult to distinguish on left side. Okay, I think you understood that. The diaphragm is seen as a relatively thin structure outlined by free gas below and lung above. Okay, this is normal. Okay, the free gas under the right and left hemidiaphragm may join across the midline under the central tendon. This is the cupola sign. Cupola sign. I will show you in the image. This is the normal pneumoperitoneum. We can all see a thin linear of gas here. This is the pneumo component, that is the air we are seeing beneath the right hemidiaphragm, and we can all appreciate that this white thing is the liver shadow. Okay, this is the surface of the liver, and this is the diaphragm, and these are the lungs. Okay, you all check it once that on the left side it is not possible to differentiate that the air is below the diaphragm is there or not. See here, this is the splenic fracture, and they are obscuring normal stomach bubble. They are obscuring the what, and this is the cupola sign. Okay, this is air under the right hemidiaphragm, and also seen in the same way and also seen below central diaphragm. Okay, this is the cupola sign. Please make it note. This is a very important sign. There are many circumstances when interpretation of an erect chest X-ray is difficult. I will tell you the most frequent situation in which perforation may be wrongly suggested or diagnosed during pseudo-pneumoperitoneum. This condition is normally seen in pseudo-pneumoperitoneum. It means it's look like a pneumoperitoneum, but it's not. In that condition, actually, a lateral decubitus radiograph can resolve the problem by demonstrating gas between the liver and the abdominal wall. Okay, please make a note. During pseudo-pneumoperitoneum, you have to distinguish between the perforation is there or not. You have to look for. You have to take in lateral decubitus radiograph, which will resolve the problem by demonstrating gas between the liver and abdominal wall. It is important to consider clinical findings during interpretation of the abdomen radiograph. Okay, if we see any air in the under diaphragm and then patient is not having any symptoms, in that condition we have to cross check with the patient how is the patient condition, what physician is suspecting, and what the abdominal radiograph findings are there. We have to interpret both. Okay, it is also important to be able to recognize the signs of pneumoperitoneum on supine abdominal radiograph. I will show you. This is a lateral decubitus sign. You will see in pneumoperitoneum. In this is the air fluid level. This is the air level. See, this is the air and this is the fluid level. Sorry. Okay. The black arrow is the free fluid in the peritoneum, and the white arrow is the abdominal free air. Okay. And we can all also see this is the liver surface. Okay. This is the liver surface. And surrounding we are getting the air, free air. Sorry. Okay, this is a lateral decubitus sign in pneumoperitoneum and condition that can simulate a pneumoperitoneum. And if we find any free air in the plain abdominal radiograph, okay, what are the conditions which simulate pneumoperitoneum? Actually, we will think of the normal pneumoperitoneum. In that condition, normally we will go for any perforation. In these conditions, only the free air will come. Okay, but some other condition they will mimic as a pneumoperitoneum. In most of the situations, it is a very important the Chilaiditi syndrome and the Chilaiditi sign. I will show you in the next radiograph. It is very important. Okay, it is almost all looks like same as pneumoperitoneum. The intestine, actually what will happen in this condition is the intestine, the large ball. Okay, mostly the large ball, that is transverse colon and ascending colon. Okay, ascending and transverse colon, that is mostly hepatic flexure. Okay, you will all see that it will goes below the diaphragm. Okay, it will cross the liver and goes and settles down below the diaphragm. This condition is known as Chilaiditi. Okay, and in some other conditions like subphrenic abscess and curvilinear atelectasis in the lung. And during lung collapse also we will find this same situations. And in subphrenic abscess, what will happen? So there will be an air fluid levels in the abscess. Okay, due to infection, there will be some air fluid levels in the abscess. It will be mixed like pneumoperitoneum. Okay, and diaphragmatic irregularity or multiple hums. Okay, in these conditions, diaphragmatic irregularity also sometimes it will, if we are unable to see clearly the gas between that. Actually, if it is irregular, we are unable to distinguish that lung, the inferior margins of the lung. So in that condition, it will mimic a pneumoperitoneum. And during sometimes the subdiaphragmatic fat also, if more subdiaphragmatic fat is there, it will also mimics like pneumoperitoneum. And the cysts in the pneumatosis intestinalis. Okay, what is it? Pneumatosis intestinalis. This means the gas which lies within the bowel wall. Okay, it is not outside the bowel wall. It is within the bowel wall. Okay, And we actually first normally during infections, the normal cysts will be there and they will rupture, and then after that sometimes perforation occurs, sometimes it won't. Okay, if cysts are there in the bowel wall, in the pneumatosis intestinals, it will mimic like pneumoperitoneum. Okay, and this is the most important for you for your need also, and you can see the air under the right hemidiaphragm. Okay, and we will see the very large amount of air here from the right hemidiaphragm, and the liver is pushed downwards and medially. Okay, and in this X-ray, what we have to look is nostril folds are there within this air pattern. Okay, I told you previously for large bowel obstruction, these are the identify. I didn't we have to look for the hostrations. Okay, if hostrations are there, it is a large bowel. Okay, if valvular conventis are there, it is the small bowel. I will show you in the next slides what are the valvular conventis and like this. Okay, this is a large blood because we are getting hostile bowls. Okay, this is Chilaiditi syndrome, and in subphrenic abscess. Okay, these are the CT, this is the radiograph, and this is the CT axial sections. Okay, in the radiograph, you will all see here below the right hemidiaphragm, we are getting air fluid levels here. Okay, it mimics like an pneumoperitoneum. Okay, but it is it is loculated air under the right hemidiaphragm. Okay, this is you can see here, and we are confirmed this with by doing CT. Okay, it is a contrast enhanced CT, confirm the presence of subphrenic abscess. Okay, this is a air, and this is the pus. Okay, this is the abscess. Okay, completely below the diaphragm. Okay, this is the subphrenic abscess. It will mimics like a pneumoperitoneum. Okay. Coming to the science of pneumoperitoneum on a supine rate. These are all very important for your need point of view, and you have to know all the signs of these. Okay, what is inverted V sign, what is Morrison's Pau sign, what is double wall regular sign, and how falciparum ligament and the all things. First, I will go by one. In right upper quadrant gas, if you find any gas in the right upper quadrant, that is in perihepatic, subhepatic, and in Morrison folds, and in fissures of ligamentum teres. Okay, then these are the conditions we will get on the right upper quadrant gas. After that, regular double wall sign. Okay, this is seen if the intra-abdominal free air around 1 liter. Okay, if it should be more than 1 liter of gas should be there to visualize this regular double wall sign. Okay, I will show you some slides after that. And during ligament visualization, sometimes they are visible like falciform ligament. Okay, that is the ligamentum teres and medial umbilical ligaments. And this sign is inverted V sign and triangular air. Okay, these are some signs. Okay, we have to look for on a supine radiograph. Okay, this is the invert V sign. Okay, inverted V sign. This is the radiograph we have to take in supine position. Okay, and we will demonstrate a free air outlining the lateral umbilical ligaments. You will see here. This is the free air. Okay, coursing inferiorly and laterally from the umbilicus. Okay, coursing inferiorly and laterally, both sides. In infants, normally the umbilical arteries, and in adults there are inferior epigastric vessels will be visualized. Okay, please make a note. In infants, it is they are umbilical arteries, and in adults, inferior epigastric vessels will be visualized. In approximately half of the patients, with pneumoperitoneum, gas may be detectable on a supine radiograph with free air in the right upper quadrant adjacent to the liver, lying mainly in the subhepatic space and hepatorenal fossa. This is the hepatorenal fossa. This is Morrison pouch. We will find gas in these situations. Okay, and lying mainly in the subhepatic space and hepatorenal fossa. These two are very important. And after that, visualization of both sides of the ball wall, outer and inner, is known as regular sign. Okay, what is the regular sign means? Visualization of both sides of a ball wall, outer and inner. Okay, because of perforation, what will happen normally inside the bowel wall we will find gas, and due to perforation the gas will leak into the peritoneal cavity and we will find outside also gas. Okay, in that conditions the bowel wall, if you see, if we notice the bowel wall, we will find both sides air surrounding bowel wall, that is outer and inner gas. Okay, it is difficult to appreciate if several loops of bowel lies close together. If so the bowel loops all are collapsed or close together, it is difficult to distinguish. Okay, I will show you in the image. Um, the pneumoperitoneum may also be detected on abdominal radiograph. Okay, when the falciform or middle umbilical ligament are outlined by free gas lying on either side. Okay, or when air is seen in the fissure for ligamentum teres. Okay, I will. This is a regular sign. Okay, you can all see here the bowel walls are clearly seen here due to inside gas is there and outside also free air, the free gas or air is there. It's also known as a double wall sign. Please make a note, it's also known as double wall sign. It is a sign of pneumoperitoneum. The bowel walls are clearly outlined by a gas present within the lumen as well as in outside the lumen. It is seen with a large amount of free gas, that is, I told you already, that is 1 liter, that is around above 1000 ml. Okay, this is a regular sign. Is the visualization of the bowel wall clearly on an abdominal radiograph. Okay, this is the double wall sign. Actually, I want to tell you the CT is the most sensitive investigation for reduction of free peritoneal gas. Most sensitive investigation is the CT. Okay. What is the first line of investigation is abdominal radiograph. Small volumes of free gas can be seen over the liver and anteriorly in the central tendon or in the peritoneal recesses. Not to miss small amount of the free gas, we don't not to miss the small amount of free gas in the images should be reviewed on a broad window settings. Actually these are the CT things you don't know mostly what are the broad window settings. Example, long windows and mediastinal windows. In CT some windows will be there. Okay, if you are aware of that, then you can understand. Please leave this. There are a number of causes for pneumoperitoneum without peritonitis. Okay, I will show you in the next day. This is the free peritoneal gas due to perforated viscous normally. Okay, these are the CT windows. This is the normal mediastinal window. Okay, this is the broad window. Actually, in broad window you will see free air clearly. If it is present, then it will be clearly seen in the broad window settings. Okay, actually, it is very little bit difficult to know which window is this for you. Okay, I will skip it. And coming to the causes of pneumoperitoneum without peritonitis, the silent perforation of viscous that has been sealed itself in the elderly conditions mainly. Okay, these are the normal conditions in elderly people and in patients on steroids. Okay, and in unconscious patients and the presence of other serious medical conditions. in deliberated patients and bedridden patients mostly. Okay, in this condition there will be a silent perforation of viscous will be seen. Okay, actually normally it will be sealed off. Okay, normally it won't actually, if the patient having that perforation also, we don't have any symptoms and any acute abdominal conditions. And during post-operative period up to 7 days. Okay, and normally during post-operative period actually the surgeons use it to induce gas into the abdomen. Okay, to freely perform his surgeries. Okay, they will induce a gas into the abdomen. In that conditions, it will mimics like pneumoperitoneum. Okay, without any peritonitis, we will see gas in there. And during peritoneal dialysis also, and in perforated cysts in pneumotosis intestinalis. I already told you pneumotosis intestinal, what is that? Gas within the bowel wall itself, and due to some cysts, if they are perforated, okay, it will also mix like a it is also one of the causes of pneumoperitoneum. Okay, but there will be no peritonitis. And tracking down from the mediastinum, stercoral ulcerations and vaginal tubal entry of air. Okay, and after that coming to the gas in the bowel wall. Okay, if linear gastrics are seen in the bowel wall, that is, I already told you that in pneumatosis, intestinal infarction should be suspected. Okay, please note that mostly during intestinal infarction, okay, if there is any loss of blood supply to the bowel, okay, there will be a linear gastrics in the bowel wall. Okay, it should be suspected most of the times. If we find any pneumatosis, that is gas within the bowel wall, we have to think of that intestinal infarction. Is there some intestinal infection? Okay, later if we don't diagnose it as early as possible, okay, the bowel becomes gangrenous. Okay, due to loss of blood supply. Okay, it's a very worsened condition. Okay, that's why it is very important to look for a linear gastrics in the bowel wall. Okay, the intestinal infarction is a grave condition caused by thrombosis or embolism. Okay, this is caused by due to thrombosis or embolism of the mesenteric vessels such as superior mesenteric artery. This is the most common. Intraliminal gas in the mesenteric veins. Intraliminal gas in the mesenteric veins or portal vein may be seen in advanced cases. Okay, these features can be readily demonstrated on CT. Okay, to look for this mesenteric vein, portal veins, gas, intraliminal, we have to go for CT. Okay, it is not possible on abdominal radiograph. The pneumotosis cystoides intestinalis is an uncommon condition consisting of benign cyst-like collections of gas in the walls of hollow vessel. What is that? Pneumotosis cystoides intestinalis. It's an uncommon condition. If you are preparing for any PGI examinations, okay, this is most important. Okay, I think now we don't have any separate exam for the PGI certificate. Okay, leave it off that. The left hemicolon, that is pneumatosis coli, is the most common site. Okay, for bowel wall gas. Left hemicolon is the most common site for pneumatosis. This condition is known as pneumatosis coli. Okay, pneumo means air. Pneumo means air or gas. Okay, present in the colon. That's why it's called as pneumatosis coli. The most common site is the left hemicolon. This is the condition actually in small bowel ischemia case. This is okay. We can see thin linear gas type air here and here also. Okay, and we will see these are the valvular conventives. Okay, not hostations, valvular conventives. Okay, hostations are in complete. Okay, valvular conventives are complete. There are thin linear lucencies in the distal ileal wall, such as pneumatosis. Note that this may be very subtle. Very subtle means very little, but normally if I am showing you the arrows, then you are able to identify. If I give you this in radiograph to you, you don't actually think of it's normal. Okay. In the same patient, we have taken an CT, and we can appreciate clearly linear of gas. Okay, linear lucencies here. These are the gas within the bowel wall. Okay, and this is the bowel wall. Actually, this is a contrast enhanced CT. Okay, normal bowel wall will be, you will see here, this is normal small bowel wall. It is enhanced. It means it's look like hyperdense. Normally density compared to it, this is higher. Okay, compared to the bowel density. But if you see here, there is no such hyperdensity here in the bowel wall. This is due to because of obstruction. Okay, that is due to mainly due to ischemia. Due to ischemia, this bowel wall is lack of blood supply. That's why it is not taking that contrast. Okay, this is the case of small bowel ischemia. Okay, in this matter, they will give you the hyper enhancements of the bowel wall and surrounding inflammatory changes. Okay, you just make a note. That's it. Okay, just we'll concentrate on this radiograph only. These are the thin linear lucencies in small bowel ischemia we had to look for, and valvular conventives. I told you I will show you that valvular conventives are. And coming to the gas in retroperitoneum. Gas can escape into the retroperitoneum, and causes of this include perforation of posterior peptic ulcers, perforated sigmoid diverticular diseases, colonoscopy, and other iatrogenic causes. Okay, the gas may be best visible in the flanks or around the kidneys. The retroperitoneal gas can track superiorly into the mediastinum and inferiorly into the buttocks and thigh. Okay, see the pattern how it goes. The gas in the soft tissues of the left thigh is a classical site for the gas of a diverticular perforation. Okay, this is the case of retroperitoneal gas. We will see here in the gas in the retroperitoneum. Actually, this is the renal, actually kidney area. Okay, the borders of the surface of the right kidney, and we'll see linear lucencies surrounding the kidneys. Okay, and you will also see some retroperitoneal areas. Actually, in this on the left side, you will also see here, and we have confirmed the same case with this. Okay, you can see this is actually an area of IVC. Okay, that is IVC surrounding this. Also, you will find gas, and these are the kidneys, and surrounding this also we are finding, and retroperitoneal area. This is all retroperitoneal area. Okay, we are finding gas and gas in other organs. Gas may be seen identified in the biliary tract, portal veins. I already told you previously in the biliary tract. Okay, in this area, actually, this is the gallbladder area. Actually, in this case, this is completely filled with gallstones. Okay, they are calcified. Gallstones are there. Okay, that's why we are clearly able to appreciate in this on plain abdominal radiograph. We are seeing that gallstones. Okay, actually in this area normally you will find any biliary tract perforation is there. You will identify in this area. And after that in portal veins, and here also the portal veins are there, and some renal collecting system. It is In this, actually, we will see that in the renal collecting system, okay, we are getting 3A here. It is a case of emphysematous pyelonephritis. Pyelonephritis, kidney infection, and this is a completely free air in the calyces. Okay, will all and this is the pelvis and these are the ureter. Okay, this is the ureter, and surrounding this kidneys also we are getting some cysts which are filled with fluid levels, and this is the case of emphysematous pyelonephritis. Okay, if we can find that distended ureter and distended gas filled renal collecting system. Okay, this is for this purpose only I have put this image for you. And in pancreas, infected necrosis are in abscesses, gallbladder wall, and gallbladder and urinary bladder. In these conditions, in these organs also, you'll find failure. Okay, thank you so much, and thank you for your patience also.